Okay. Good morning, everyone, and thank you for being here. I'm going to do my best to sound like Dean Anthony Crowell, so I'm going to make some introductory comments and introduce our panel. If you caught this morning's panel, we're already here and have some really important conversation. Um, we're going to have a really in-depth conversation today that's, I think, very timely and very exciting for many of us who are interested in this space right now. My name is Adam Herbst. I'm a partner at Sheppard Mullin and someone who spent much of my career at the intersection of health policy, law, and innovation. Before joining the firm, I served as a special advisor to Governor Andrew Cuomo and as deputy commissioner at the State Department of Health, where I oversaw much of the work on technology strategy and Medicaid transformation. Today, I advise health systems and payers, investors, and startups on how to scale responsibly in an environment that is rapidly evolving. I want to say a big thank you to the dean and the entire New York Law School community for opening today's session and allowing us to have a commitment to convening such a timely and important conversation, which is at the crossroads of law, policy, and innovation. It's truly a privilege to be a part of the effort today. I also want to recognize Professor Steve Pegalis, who's here with us today. Steve is a founding partner at Pegalis Law Group, a longtime leader in patient advocacy and healthcare law. He's also my co-director at the law school's Healthcare Law and Policy Student Association, and like me, serves as an adjunct professor here at New York Law School. Steve continues to have a leadership role at the law school and mentorship, and his mentorship is instrumental in helping to shape the next generation of legal and policy minds in healthcare. I also wanted to bring this panel together today with some really expert thought leaders at this critical time. AI is moving faster than our ability to regulate and evaluate or even fully understand its clinical and ethical implications. At the same time, we're seeing real promise, reduced diagnostic delays, streamlined operations, and better targeted care. But the question remains, what's truly working, what's just hype, and what do we do still that we need to get right? The session today is designed to be a practical, thoughtful, and honest conversation. We'll explore not just the tools and technologies, but the systems and safeguards that we need to make AI work in real clinical settings. And we hope that this is the beginning of an ongoing dialogue, with today as a chance to share ideas, ask some really challenging questions, and lay the foundation for collaboration going forward. So let me briefly introduce our panelists and leaders who bring a powerful range of perspectives to the conversation today. First, Dr. David Rich, President and Chief Operating Officer of Mount Sinai Hospital in Mount Sinai, Queens. He's led on the front lines of AI integration and quality-driven transformation in one of the country's most complex academic medical systems. Thank you for being here, Dr. Rich.
My pleasure. Thank you for inviting me.
Elad Walach, a co-founder and CEO of Aidoc, a global leader in AI-powered medical imaging and decision support with deployments across hundreds of hospitals across the world. Thank you for joining us, Elad.
Great to be here.
And Dean Michael Pastor is the Dean of New York Law School's Technology Division with deep expertise in healthcare law and innovation, and a thoughtful voice on ethics and regulatory realities that must accompany the rapid tech advancement. Nice to see you, Michael.
Adam, thank you for having me. And on behalf of New York Law School, my thanks to the Sheppard Mullin team and you for making this happen.
Thank you, Michael. So, we're going to jump right in. We want to make sure the time is really useful for today's conversation. And I want to explore a bit, but I'm going to first introduce a few questions for each of the panelists in targeted questions. And I thought it would be very interesting to hear their distinct points of view. So I'm going to start with Dr. Rich with one question, where he has seen, Dr. Rich, in your experience, where have you seen the clearest return on investment or measurable clinical improvement from AI integration at Mount Sinai?
The most effective tools that we've developed so far occurred both from internal development and also working with partners. So I'll just give two examples. We developed a malnutrition prediction algorithm, which was very effective in getting our dietitians to the right patient at the right time. We tripled our rate of recognition, diagnosis, and treatment of severe protein-calorie malnutrition, which is much more prevalent in hospitals than people realize. And that has an advantage for us in, of course, treating our patients more effectively, improving outcomes. But it also is a major comorbid condition, so it increases hospital facility reimbursement. And the second thing, which I think we'll explore in more detail later, is that long-term partnership between Mount Sinai and Aidoc under the leadership of Elad Walach, where we have, I'll give an example that when a patient last night, underwent a CT scan and we diagnosed a condition that is very, very life-threatening, a mortality rate of 1% per hour, something called aortic dissection. I don't know about last night specifically, even though it happened last night, but in general, our surgeons are getting a text and notification from the AI algorithm that identifies this before the radiologist has even read the examination, saving lives.
And how do you weigh those gains against concerns about training and unintended disruption?
Well, you can never stop looking at quality, safety, accuracy of the algorithms, because the joke I tell is that all predictive analytics are local. And so whenever you develop something, it will have issues, and not everything is perfect. So you always have to have the licensed person who took the oath and has the obligation to serve being integrally involved in the process. And then the second thing is we train our models, not so much in imaging, but in the rest of the electronic health record, on data that are inherently a bit biased because we have different levels of access in this nation. So being constantly vigilant to biases that may exist in our predictive models, again, is something which is critically important to us.
Great, thank you. Elad, what's one real-world example where AI doc has made a measurable difference at scale?
So, first of all, I will say one of the areas that I'm most excited about, if I think about the impact of AI, is utilizing data that we already have much better. Healthcare today is roughly 30% of all global data. That is a striking figure if you think about how much AI is actually utilized to generate outcomes. And I'll give one example, actually Mount Sinai have been a leader in, which is coronary artery calcifications. So those that don't know, it's becoming very hot in the VC circles to do this calcium scoring test. But effectively, it's a study that you do. It's a CT of the heart, and effectively it's simple terms. And David, please excuse me if I'm butchering it, but it's a great predictor for heart disease. One of the best predictors we have that we can do in a fairly screening fashion. But today, most people have to ask to do this exam. And not many people know that they can do this exam and have the prediction of heart disease. If they find any predictor, they can then treat it, for example, with medication like statins or behavioral. So heart disease, if you catch it early enough, easily, not easily, but somewhat preventable. But the problem is you have to ask for it. I think we have this immense opportunity to give it automatically. And one of the amazing things that we're running together, and Mount Sinai have been a leader in the nation on, is saying, look, we already have all these patients that are getting their imaging of the chest. Why wouldn't we already screen them for that disease? And then, so when a patient is getting a CT scan of the chest, they're already, now with AI, right? Mount Sinai is already looking for this calcium scoring, and they can give you that predictor. Not only that, now the AI have these agentic capabilities that connect the imaging information with your clinical history. So it's not just based on an image, it's based on your holistic patient view. And based on that, they can bring back patients and tell them, hey, you potentially have heart disease risk. You should get, you should be seen by a cardiologist. And the numbers are pretty striking. It's hundreds of new patients every year that didn't know they have heart disease risk that now can get it. Think about you as a patient getting that call. You do whatever it is, you fell down a few stairs, you're doing screening for something, and then you get the call from a health system that, proactively cares about you and tells you, hey, you actually have heart disease risk. You should see somebody to treat that. I think there's immense opportunity with that if you think about it from a population perspective.
If I can I add to that, Adam, for 1 second? Yeah, the partnership is very important here because one of the hidden treasures that we have in terms of advancing healthcare is millions of images and millions of electronic health records. And to be able to put together predictive models, which include what the radiologists refer to as opportunistic screening, meaning that, it's already there on a chest CT or an abdominal CT. We see osteoporosis, calcification of coronary arteries, potentially nodules in lungs. These are things that could help us provide much better care to our population at large. When you think just about osteoporosis, for example, it's an epidemic in our nation, predominantly affecting women, predominantly people over 70. And if we can effectively identify and get people into treatment programs, we can prevent fragility fractures and extend people's, frankly, contributions to society and their mobility and their quality of life.
Michael, why don't you jump in here? Do you agree or do you believe that we are ready for the broader adoption based on what David and Elad are saying?
Yeah, I do. I mean, so I'll come at this from the lawyer's perspective for a moment because that's my training. And what's so interesting about these conversations is that lawyers have been doing what they do for centuries, and doctors have been doing what they do for centuries. And I think it's important as a baseline point that we acknowledge that those years and years of training, doctors and lawyers, gives us a baseline ability to handle this question. Right, like we have a new thing here. What will it do for us? So I feel like we often skip the baseline foundational knowledge that physicians and hospital administrators and the lawyers who work in those companies already have as we approach this thing. So we have that baseline ability to be optimistic. When you frame it as ready, Adam, I think what I always turn to in AI discussions is, are we seeing the tools customized to the particular user, right? So technology has been deployed for decades to do a variety of different things. What I think of as extremely exciting about AI is that there's a chance that each tool can get better in its interaction with its user. And that's where I really think we're going to want to see, are the tools getting better as they perform, as they operate with the doctors, and hospitals. And I'll give what I think is an interesting framing for that. For those of us who've gone to physicians, and a lot alluded to this in terms of the people who care for you, right? When you go to a physician, who've been the best physicians in your life? The best physicians in your lives are the ones who've gotten to know you. They got to know your approach to things. They obviously know your data, like your medical history, but they also know you. And sometimes decisions with a patient will be very scientifically driven, but frequently they won't. The doctor will say to the patient, well, we have two options. Let me tell you what the options are. And let me help you guide your decision making, because ultimately this is your decision. I mean, think about how fascinating that is. We have the best doctors in the world. And yet sometimes they need to turn to their patient and say, I need you to make this decision. It's up to you, based upon your risk tolerance, based upon your goals, all those different things. And in that moment, what you want is a physician who's gotten to know the patient. And I think we really should be striving to have technology that does that as well. That, to me, is the major upside here. We can talk about risks. I'm sure we'll get to some risks, but the major upside here is technology that improves over time as it interfaces with the user.
Elad, do you want to comment to that? Do you agree?
I agree. One actually interesting question I have is if you think about these examples from David and I wonder, Michael, do you think it can become malpractice soon to not use technology if you know that's, for example, the example David gave, finding osteoporosis, can you now not utilize it?
Fascinating. So I'm not gonna dip in the medical malpractice waters whatsoever. It's not what I do, but I can talk a little bit about legal malpractice. And absolutely, lawyers now are obligated under the codes, under our rules, to be up to speed on this technology. So I think yes, it definitely will be legal malpractice at least to not soon use these tools when you're advising clients. And I presume that it might be, again, I don't know medical malpractice standards in that way, but I presume at some point in time we'll get to a point. And if I make one other point, which I'd love to hear the doctor point and Elad's point, I think there's an upside to AI where we identify pain points in the life of a practitioner, doctor, and those points of friction, I think, can really add up, and keep people from doing the things that they want to do. And I think there might be a potential here for AI there to both identify where doctors are having friction in their day-to-day life, where patients are having friction, and maybe utilize AI to identify some ways to reduce that friction. I don't know, doctor, what you think about that point.
Well, to address the last part of it first, I believe that one of the biggest problems that certainly I deal with on a daily basis is lack of care coordination. It's very easy for people to get lost in the system, to get told there's no appointment available for months, for someone to say, oh, you need this test, and very challenging to get the test, and then the result has to get back to the provider. There's a lot of dropped balls. And agentic AI models can be very helpful. Decreasing documentation burden with ambient AI tools, et cetera, can be very helpful. But going back to the medical malpractice question that Elad was talking to, we really are in a regulatory wild, wild west right now. What we've tried to do at Mount Sinai is generally not have AI being patient-facing, that it's focused on getting the right team to the right patient at the right time, enhancing some internal processes and making things more efficient. And so we started now with an agentic model that interviews people before catheterization and just does a nursing pre-screening questionnaire. But before we did that, we had to revise our general consent for the hospital, because we really didn't have anything that said AI might call you and ask you questions that will become part of your medical record. And so we're in an area where we need a lot of leadership, both from government. The problem, of course, it's a regulatory, zoo out there. You've got Joint Commission and CMS and state departments of health, et cetera. We have very little guidance in terms of how to use AI, but we always try to come back to the idea that, a licensed provider, my joke was the person who took the oath is responsible for your care. So we still cannot forget where that baton of responsibility lies. It doesn't lie with the AI, it lies with the practitioner.
In my previous role with government, I saw firsthand how regulatory structures struggle to keep pace with innovation, right? And also how much providers are looking for clarity and guardrails, to David's point. I guess my question, though, is, in your opinions, who should take the lead? Should it be the elected officials? Should it be departments of health? Should it be the clinicians? Who should take the lead in helping to put that regulatory structure together?
Anybody?
Can I jump in here, Adam?
Please.
A recent paper in a leading medical journal gave a list of how to avoid lawsuits. Practice good medicine. Treat every patient as if it was your family member. See your patient. Respond quickly to an emergency. Do not cut corners. If the patient fails to respond to therapy, look again. Make sure you see and interpret test results. Always think about the worst case scenario. Team treatment requires somebody in charge. Involve consults if needed. Let go of ego. Communicate, talk directly to your patient. Talk directly to consultants. Weekends, holidays, and nights are particularly treacherous. You know what's not on this list? Does your institution have an AI program to make care more efficient? If not, why not? If yes, how do you know your AI care, your AI plan is working? How do you know it's the best care? How do you know it's being used properly? How do you know it coordinates with this list of common sense do's and don'ts? The Journal of the American Medical Association published a paper recently, very recently. Quote, AI has entered the medical field so rapidly and unobtrusively that it seems as if its interactions with the profession have been accelerated without due diligence or in-depth consideration. It is clear that AI applications are being developed with the speed of lightning. And from recent publications, it becomes frightfully apparent what we are heading for, and not all of it is good. They talk about AI snake oil, and they talk about proceeding with caution because of the dangers of overestimating AI's abilities. There is a recent advertisement from one of our major New York City institutions. Quote, we're using artificial intelligence for more precise breast cancer diagnosis. Close quote. Well, is my institution using AI for more precise breast cancer diagnosis? They state in the advertisement, error accuracy counts. Really? I said the right treatment sooner is better. Really? Well, AI is entering the field of medicine with the speed of lightning. Let's be careful. But I gave a list of common sense do's and don'ts. Nobody has any difficulty in understanding that list. AI does not exist separate from that list. And there once was a disease called tuberculosis, and there was no treatment. Now it's curable. Well, if you don't cure it with that treatment, you're not using proper care. Same thing with AI. What can it do and what can it not do?
David, do you want to respond to that?
Yeah, I think I will make a couple comments. I'll quote our chair of radiology, who says that AI won't replace radiologists, but radiologists that use AI will replace those that do not. And today, when you have access to your medical records at Mount Sinai, and due to regulatory requirements, actually it was legislative requirements in the U.S., we are required to make our medical records available to our patients in a very short period of time. So much so we get unintended consequences of people finding out very scary diagnoses before the doctors had a chance to talk to them. But as an example, a mammogram will be read and will be dictated. And once it is dictated by the radiologist that is responsible, it will be in the patient's medical record. And that medical record will indicate whether or not AI participated. I think that let's put participated in air quotes because I'm not sure the correct terminology, but AI was involved in the diagnosis. But in all cases, with mammography, we're doing that. There are FDA applications now, for example, doing retinal screening in patients who have diabetes that can grade the degree of, this is retinal scans within the eye, it can grade the degree of damage to the blood vessels in the eye that is caused by the vascular disease that's associated with diabetes. And so we're seeing some autonomous AI applications that can make diagnoses, but for the most part, people will see it in their medical records as part of the documentation.
Some years ago, I know Dr. Reich is background is in anesthesiology. In 1983, the anesthesiologists began to study closed medical liability cases.
Mm-hmm.
And by the year 2000, they had made anesthesia the safest medical practice available. The statistic was 1 out of every 10,000 procedures, there was a death. After their studies, it was 1 out of every 200,000. And the year 2000, the Institute of Medicine cited the standards, and the only medical specialty they were able to cite to support their proposition was anesthesia. How could it be that anesthesia was the only medical specialty that studied the closed cases and none others? But since I'm sure you're very familiar with the Institute of Medicine. To err is human.
Right. Well, if I could respond, first of all, it's very nice that back in 2000 that anesthesiology was recognized. But since I'm talking to a lot of attorneys, it was largely because of a malpractice crisis that the closed claim study was initiated, and it accelerated the adoption of monitoring standards. So this is helpful. But I think to sort of relate that to what we're dealing with 25 years later now, again, where there are a lot of issues within medicine. There's a lot, I referred to the drop balls before. There's a lot of delayed diagnoses, challenges in care coordination. And we have an opportunity now to take advantage of technology, as we did back in the 80s when we introduced pulse oximetry and measuring expired carbon dioxide from endotracheal tubes to stop some life-threatening challenges. So I would say we're in the same place today. The techniques are different. The application to many more specialties are different. But how you safely, and effectively implement technologies that improve patient outcomes, I think, is the eternal question for all of us. The blood pressure cuff was an advance, and that started, between 1900 and 1910. Thank you, Harvey Cushing, the surgeon, from neurosurgeon from Hopkins that insisted upon that.
All right, I want to move on. I want to ask a lot of questions, just and also for the group. I just, where's the bar for transparency, Elad? Should every clinician in your expertise understand how the AI they're using works, or is it enough to trust the system and follow the guidance?
So I'm a big believer in education and transparency. And I think we have to recognize that the human psychology is that we learn to lean on things that make our life easier very quickly. So I found it extremely important to educate about the limitations of the technology and not just the benefits. And I can give plenty of examples, but one thing that we do actually in training, we give examples where the AI was wrong. And we show why it was wrong. There are typical reasons. It was something in the imaging modality, it was something in the context. And we have to recognize that AI is not perfect. I think those of us that use generative AI like ChatGPT in their day-to-day, on the one hand, it's amazing and it's striking, but it's definitely not perfect. I am not sending auto emails that my ChatGPT is writing. I'm using it to help make sure, to help me improve the language, but I'm not using it to auto send things. And I think at the same time, we will look at this very similarly with us humans. Um, and I don't think it's going away. I think people sometimes say there are hallucinations in ChatGPT, right? It's the equivalent of a false positive. And some people tell you, well, hallucination will be solved in the next version. I don't think you can ever solve hallucinations. Like you can't solve false positive. You can improve and reduce the rate you have them. That is for sure. But expecting a 100% system is not going to be, I don't think it's possible in the near future. And therefore, we have to train the humans of how to actually use them appropriately and safely.
Let's play a little bit more on the clinical judgment and autonomy. Does anyone want to push back on what Elad is saying there, or do you see this playing out at least differently in academic versus the community setting or in practice itself?
I'll certainly comment. One of the challenges that physicians are facing, and really providers of all types, is that patient portals, have created a vast burden of messaging that has to be managed. And that is, we refer to it as pajama time, because after people go home and put the kids to bed, they have to go back to work and start to clear out their inbox. And so the ability to have tools like AI tools to say, okay, this is a request for a medication refill, doesn't even need a new prescription, I can handle that. This is a request for a repeat appointment, I can handle that. I think there are ways to help manage our medical professionals' lives that can make them much more efficient, so they can focus on a real problem. Someone who's calling in, would say, with new symptoms that could be very concerning, that needs to be addressed in a more rapid fashion. And that way, instead of having, 1 in 100, the needle in the haystack, you might have 5 messages, let's say, that require actual, interaction and thought and response. So as much as we have to always be concerned, and technology is by definition, I would say, almost always imperfect, and we always have to exercise vigilance, I think that we can reap benefits, but still be cognizant about the fact that nothing's ever perfect. And it goes back to what I said before. It's about quality assurance. You have to make sure that these tools are doing the right things with your in-basket and not missing something important. And again, frankly, avoidance of bias, that if someone is not so proficient in English, or we're answering and having translation services as part of it, we have an opportunity to mess up again. And we have to always be on guard for that.
Yeah. Michael, let's also take a beat there, on bias and fairness and safety. Clinical AI is only as good as David and Elad are saying, as the data it's trained on. How do you see, from a legal perspective, ensuring that the tools being used don't bake into the systematic bias, especially for underserved populations, Michael?
So a couple thoughts on that. I want to track back to a question you asked earlier that I didn't get to because it relates to this question. You had asked the question sort of, what's the role of government in all this? One thing I will say about that is sometimes with tech, things feel like they're going so quick. I think that government officials at various levels can get a little bit frozen, a little bit paralyzed. And there's also often a push on the tech side to say, hey, government, I want you to stay out of this. We know our tech. You don't understand this. Please stay out. I would like to push back against that. I think there is a place for leadership at all 3 levels of government in the United States, local, state, and federal level, on this question. To your point on bias, Adam, right? I think that those in government should be thinking about what data sets are being used. Are the data sets being used lawfully? We might as well pause right there. I mean, Elad spoke to the breadth of the data, which is amazing. The only question there is, like, do we know if that data is being used lawfully? in the initial instance? Is it being used with an eye on data privacy, which we haven't really hit yet? But I think there's a place for policymakers working in conjunction with the industry, right? I'm not a believer in policymakers working in ivory towers. They should work with the hospital community. They should work with doctors. They can work with the legal community, legal academia. But I think there's a place for them there. And in fact, government actors thinking about how to remediate bias is something we've done before. We have done this before. And in fact, there's a local law here in New York City that's focused on automated decision making. So I think there is a place for government actors there. I think it can be done. I'm confident it can be done. It also takes leadership, like the doctor being a leader. Leaders have to buy in always, but I think it can be done.
And
David, to that, go ahead, Elad, please.
Sorry, Adam, one thing I wanted to say. So I think government, can and should play a pivotal role in this. Two things I want to say. First of all, there is a lot at stake. And if you look at the data, a team of researchers from Hopkins last year published the burden of diagnostic error. And they're estimating that every year in the US, you have 370,000 deaths and 430,000 permanent disability due to diagnostic errors every year. If you try and quantify that economically, what's the burden on society from lost productivity? That's $1 trillion a year. That is a striking figure. That makes it one of the biggest problems we have. We have the most amazing tech-advanced health systems and physicians in the world. And still, life expectancy in the US is easily 3 years below most Western countries with double the expense. I argue part of it is that we have this hyper-specialized, very fragmented care environment. And look, not every place is Mount Sinai, right? I mean, Mount Sinai has access and technology and can attract amazing physicians, and a lot of care is delivered in community, so it's not equal. So we have this massive, I think, quality gap that we need to solve. That is why, and I add to that the fact that we have unsolved problems. I think Stephen mentioned this. We have unsolved problems, and Michael mentioned about the data use, about reimbursement. That's another big topic we can talk about. I think that we need to start using this technology, not because it's technology, but because it can improve how our physicians work and our patient care is delivered at massive scale. And we need to build a framework and guardrails to us accelerate that notion. If you listen to Dario Amodei, if you listen to Dario, he's the CEO of Entropic. And he published this beautiful piece called Machines of Loving Grace, where he stipulates, it's called the compressed 21st century. He believes we'll have the equivalent of a Nobel laureate in a box will be the AI. And they will create new invention and new standard of about computational biology and new standard of care very rapidly. And he called the compressed 21st century because he believed we'll take the advances of 100 years in the next decade. I think right now we don't have that capacity to implement a fraction of those. The average time to implement the new care paradigm is 17 years. Imagine you're gonna get 10 of those a week. So I think we have to find ways to change faster. This is why I think AI critical, and this is why government has to play a role, because there are unsolved problems that no single entity can solve.
Adam and I first met with a doctor named Erwin Merkatz. You recall that, Adam?
Of course, yes.
And we had a program at the law school in how to promote equal health care for all citizens of the United States, not just New York State, but in dealing with access to, for example, health care for high-risk obstetrical patients. And it was Adam's idea, by the way, that we honor Dr. Merkatz and promote the idea that everyone in the United States should have access to that high-risk care. And, it wasn't so easy. Remember, Adam, it wasn't so easy to get a politician to support that. And
I I do
so,
remember that. I do remember
so
that. Time is short. We have about 15 minutes left. I want to ask a few questions just about scaling and governance, because we touched on this a little bit. David, what is good AI governance? What does a good AI governance model look like inside a health system? Like, who owns the oversight? Clinical leadership, IT, legal, or is it a cross-functional team, in your opinion?
Very cross-functional. We try to divide the pillars up in an academic health system into the research, education, clinical, and I'd say administrative, operational sort of support missions. And it's a challenge. We've been at it for a few years now. And for example, there was I think when we introduced an agentic model to do that function I referred to earlier, where we have an agentic model that is conducting a nursing pre-catheterization interview, that it made it all the way to the point where they were starting to pilot it on patients, but no one on the committee had thought about the general consent issue, for example. So I would say it's a process that is going to be continually maturing over time. And I'm not saying it was really broken. It was just that it wasn't quite there yet. And that's just one example that, we think we're way ahead on governance. But, I turned a little pale when someone called me up to show me proudly how they were using AI to interview a patient. And, I said, oh, that's great. And then, emails started flying to make sure we had ourselves covered, because as an experienced hospital leader, I've been through many unpleasant experiences with Joint Commission, CMS, Department of Health, Office of, just name them. People can come in and give you a hard time from a regulatory standpoint. And we wanted to make sure we're dotting I's and crossing T's. So it's a brand new problem, and we really have to work on it together. And there really isn't any true guidance out there. The Consortium for Healthcare AI is one group, which has, a membership on this. Elad's a charter member, Mount Sinai is a charter member, and we would love to see consortia come together, and frankly, for the government to be an active participant and not an active opponent as we do this.
Interesting. And Elad, just play on that for a second. How you're working with so many different hospitals. How do you advise your clients in situations where multiple AI vendors offer overlapping tools? Is there a risk of fragmentation or redundancy that harms care or in the clinical setting? What do you think there?
Yeah, so you're absolutely right. And if you look at the clinical AI space, developing AI that is good enough to help physicians is very difficult. So the way the clinical AI space has evolved was one point solution at a time. Today, you have about over 1,000 FDA cleared AI devices. They've been built by hundreds of different companies. So like the average is 2 products per company. David can comment, but what health system in the world can work with 300 companies? So that is a real problem. And you also then create a lot of data siloing. If we said that data siloing is a problem to begin with, the cure cannot be creating more data silos. Now, I'll give the example. We gave the example of calcium scoring. Let me add on to that. So let's say a health system like Mount Sinai chooses, which they did, to do this proactive care to the population. And that's amazing. So now they have vascular surgery searching for aortic aneurysm that potentially has been not managed, and then cardiology for that calcium scoring, and then, interventional radiology for IVC filters and whatnot. What's going to happen? Are you going to get 10 phone calls from 10 different departments telling you they're not connected? We have to start looking at the patient holistically versus all of these fragmented points of care. So I truly do believe that as the space evolves, we will have to think about platform and governance structures where everything is connected. Otherwise, we're at risk of causing more harm than good. I know, say, fighting fire with fire, but I don't believe you can fight fragmentation with more fragmentation.
Sure. We have about 10 minutes left, and I want to open it up to some questions from the audience. So here's our first question. On the human side, and we talked about this a little bit, what does meaningful patient consent look like in an AI-enabled care setting? Is informed consent even possible when most patients don't understand the algorithms?
I think I'll take that one on. I think the point is that if assuming we have a good governance structure and we've established reliable workflows and built an AI tool into some aspect of patient care. And that's quickly becoming ubiquitous in the US, especially with solutions related to radiology applications like the great work that Elad's company Aidoc has done and others. It's already happening. So I think that the key thing is to say that, inform people that AI may be involved in their diagnosis. And so they have the opportunity to have a meaningful conversation with the responsible provider saying, well, did AI help make the diagnosis? Did AI make the diagnosis independently? I think we have to be able to have that discussion with people, both to reassure and in certain circumstances to understand that they, do not consent to AI potentially being, part of their care. And they may choose to get a different type of care or to get their care elsewhere even. But I think the key point is to make people conscious of this. And I think we all learn that in medicine that consent is not a piece of paper. Consent is a process and often a discussion.
Absolutely. Anyone else want to respond to that as well?
The words reasonable and understandable are the two key words. That has to be understandable to the layperson, and the consent or lack thereof must be reasonable. And liability can follow only if a reasonable person would not have consented had there been sufficient information. So let's not shroud this in a sea of mysteriousness. The word reasonable and understandable are the two key words, and we can go from there.
Here's another question on clinical integration and workflow. In your experience, what are the hidden operational costs of AI adoption in clinical settings, not just in dollars, but in clinical training, cognitive load, or workflow disruption? Anyone want to take that?
I also have another silly phrase that I use in addition to all predictive analytics are local. Some people may remember during the Clinton era that someone asked how you get to be elected president. I think it was Carville that said it's the economy, stupid. So what I would say for this, the equivalent is it's the workflow, stupid. And I'm not calling anyone stupid on the call or any of the panelists, but it's the need to be obsessive about workflow and workflow integration. And that's expensive. If someone came to me, I'd say, David, I got this wonderful new tool. I'm giving it to you for free. Free isn't free. Yeah. Building things into workflow takes a tremendous amount of effort on, just on the technology side, on the staff training side, and on the quality and safety monitoring side. And so I wish, Elad and his company great luck and success and all the things you would wish any company. But frankly, it would be a lot easier for me if when I bought a new MRI or a new CT, that these tools were embedded, that were already, part of this, as opposed to, again, Elad referred to it, how can I deal with 300 companies? We deal with Aidoc because they're very good and they were at the table very early. But the barrier to entry gets higher and higher because, it's much harder to deal with these immature companies where it's much harder to understand whether it's practical or not. And then again, it just comes down to cost. We're already in a bad state financially in healthcare. Current policy coming out of Washington may make that worse. And so how are we going to be able to afford these innovations? Innovations cost money.
Well said.
What is the cost?
Steve, I just want to we have a couple more questions from the audience. I want to make sure we get to the audience questions, and we have about 5 minutes left. And we can talk about this and have this discussion for another many more hours. And I hope we can come back together in the future, hopefully in person. We had a lot of people from outside of New York who wanted to join the discussion, and that's why we pivoted to an online discussion. And we have great turnout as a result. However, it's always more fun when we can do this in person, and I hope we can come back together. But in the last 5 minutes, I want to get to one more thoughtful question from the group in the audience, and then open it up for from final questions from the panel. Here's one last question. Should we require third-party audits of clinical AI models similar to drug trials or medical device testing before they can be used at scale? Yes, David, please.
And Elad can talk about this too, because he's involved in the Consortium for Healthcare AI. It started, with a group of academic centers, Stanford, Mount Sinai. I honestly don't remember all the groups. Mayo's a key player, and Mayo's actually having a meeting next week. And as part of this effort, what we're proposing as a group is to create assurance labs. Think of it perhaps as like a joint commission for AI tools, that you need to develop some kind of standard or understanding in our nation that will assure that what gets into the market is real. Now, FDA has traditionally had that in the past. But FDA, is largely focused on software that might be used as a medical device or setting something up so we could get, let's say, an autonomous diagnosis. The scope of what the FDA can do is unlikely to cover what is really necessary to have safe and effective AI tools introduced into clinical medicine. And therefore, if organizations like Mayo, Stanford, Mount Sinai, MGH, name them all, are to come together and create standards and individually set up assurance labs, as Elad develops a new tool, he could come to an assurance lab and it could be, you can kick the tires in a very significant way. And we may need to have some kind of certification process.
Elad, do you want to respond to that question before we open it up?
Yeah, quickly I'll say that the good news is for many AI tools, they are a medical device and have to be FDA regulated. So that's easy. And David is absolutely right that the boundaries of where it begins and ends are not super clear. And I think we will see, and I agree with you, so creating anything around model cards and health assurance lab will have immense impact. But I would say the scary part is that I think people are demanding more and more from the health systems, which I think sometimes, honestly, I don't think that's I know how hard it is to monitor and validate AI. Like we do this, it's a core competency. We have dozens of people doing it. It's a lot of work. It's a lot of learning. So I think we need to create frameworks that will reduce the burden and not increase it for health systems.
All right. Final question, 1 minute each, 60 seconds for each of you to respond. And this is going to be a forward-looking answer. I'll start with Michael. In 5 years, how should we define success in AI and healthcare? Not in terms of dollars or adoption, but in terms of real-world impact, especially for frontline workers and patients who most often feel left out in innovation cycles. How do we define success in AI and healthcare, Michael?
I want the doctor to take that one first.
I think success is better patient care. And there was one question in the chat that I tried to answer. We'd love to bend the cost curve, but we've kind of failed in this nation at population health and value-based care payment. We might be able to get better at that again. I gave the example earlier of osteoporosis. If we could develop agentic tools that can manage people through a complex problem, and demonstrate that we decrease the burden of disease, which has a measurable impact upon society, both financial and also just a quality of life based, then I think we'll have achieved some levels of success. I really think, Adam, you gave the most impossible question, and so the most impossible answer would just be a summarization to say that we'll know when we see it in terms of success related to basically implementing various tools and workflows and having our patients seeing it as a positive and thanking us for what we're doing. And we'll be unsuccessful if the opposite happens. And I'm dealing with a lot of your colleagues in courtrooms related to AI-related liability concerns.
I don't know if that's a knock on the legal profession, but we'll take that as an answer.
Adam, if I could jump in and take my 60 seconds, which is completely non-responsive to your question, to say this. Number one, I think we have to keep our eye on cybersecurity. We haven't gotten a chance to discuss it today, but we have some very valuable and important data in our systems. And to Elad's point about integration and multiple tools, your machines talking to each other, keep an eye on that. The second and last point I will make relates to the Roomba. The Roomba is a robot that vacuums the floor. It was introduced in 2002. I recall it being introduced. And at the time, it would have been reasonable to believe the Roomba was going to end brooms, vacuum cleaners, and mops forever. It is 2025. That is not the case. The Roomba is doing great. It's cleaning floors, but we still have brooms, we still have mops, we still have vacuum cleaners. So my view of any AI tool, it might revolutionize the world, but it also might just be another tech tool. And we should keep thinking that way. Elad, anything?
Elad,
I would
that's
say,
you.
yeah, I would say in 5 years, if AI is immensely successful, we reduced the diagnostic error rate in the world, but let's say in the US, by 90%. That would be my very ambitious, very bold target. If we do the same study 5 years from now and we get to 40,000 instead of 400,000, I think we'll be very happy.
As medicine
60 seconds for you.
as medicine becomes more complex and as good outcomes become more doable, the likelihood of lawsuits from bad outcomes should be increasing. Yet over the past decades, the incidence of lawsuits have been decreasing. 5 years from now, will we continue to see the incidence of lawsuits decreasing as over the next 5 years, the opportunities for good outcomes have been increasing? That would be a good measure 5 years from now.
Well, thank you. Thank you again to David, Elad, Michael, Steve, all of you for joining us and for all of you being part of this conversation today. This is a space that's evolving rapidly, but we have a responsibility to shape the evolution thoughtfully, equitably, and collaboratively. What I appreciated by today's conversation, and it wasn't just the insights about what's working in AI, but the willingness to talk about where it's still falling short and how we can get from promise to practice. I think we heard a lot about AI's value, which is inevitable, but it's earned. And it's earned through trust. It's earned through design that centers clinicians and patients and thought leadership that's willing to ask these hard questions. It's not just about how fast we can scale. It's should we scale and how do we scale and who benefits as we do scale. So whether you're a health system leader, a startup founder, a regulator, or a student, you all have a role to play in shaping what comes next. And the good news is we're not starting from scratch. We're starting with tools that are improving everything from stroke triage to reducing imaging backlogs, helping underserved communities get better care. And yes, sometimes it does fail, but we're learning and teaching in the process. So I think from today's conversation, we asked the question, what's next in AI? Let's ask what better looks like, not just for hospitals or investors, but for people at the heart of these systems. The nurse managing the too many alerts, the caregiver trying to make the right call in real time, and the patients who deserve care that's accurate, that's timely, and human. So thank you again to all our panelists for being here today. Thank you for joining us. If you've been listening for the last hour, we hope this has been the start of a larger conversation, and we look forward to continuing it with you soon. Thank you so much and have a wonderful day.